We're waiting for Vikram to join. In the meantime, I think we'll request Dr. Manish to.
Here, I'm here.
Oh, you're here.
Yeah, Dr. Smith here.
How are you?
So, hi Vikram, thank you very much. So, over to you, Vikram. We have 16 students, and all of them their videos on. So, we have given cases to 3 students each. Case 1. Athira, are you there? She's muted. Athira is muted now.
Let me share my.
Share your screen, Vikram.
Yeah, I'm doing that. Yeah.
Case 1 is to be discussed by Dr. Antu, Kancha, and Namita.
Okay, can you guys see my screen?
Antu is there. Yes, we can.
Yes, we can.
Antu, Kancha, and Namita.
All right, does one of you guys want to start talking about this case? So let me start. Okay, let me start by introducing myself. So I'm Vikram Deshpande, and the other thing I wanted, and I've known Dr. Gujral for 35 years. So thank you for the invitation, Dr. Gujral. And the other thing I wanted to say is, if you guys are on social media, fortunately I don't have an image for you, but please do follow me. I do post a fair amount of pathology cases, including videos and stuff like that. I also have an active YouTube channel that you should be able to search on Google. With that, let's start. So I've not given you any history, and that's one of the ways I sort of typically. Can you guys hear me okay?
Yeah, Vikram.
Yes, sir.
Vikram, briefly, Vikram, Manish has joined. Manish is going to chair your session. And,
Hi, Dr. Vikram.
Yeah.
Hi.
Okay, over to you, Vikram.
Yeah, we were there last year. I think was when we stopped.
Yeah, hang on. Sorry. Hi. Sorry, I did this. I wanna. Give me 1 second. Okay, I just want to make sure I'm using the right microphone. So then I want to use this microphone. Will you hear me better? Can you hear me?
Yes. Yeah, it's much better.
Yeah. I was using the wrong microphones. Okay. Do you guys see this? So I didn't give you guys any history. But what I wanted to do is sort of start with some very basic fundamental facts or information about bone pathology. And I remember as a trainee going back, no one actually sat me down and showed me some basics of bone pathology. A lot of bone pathology I learned on my own. And then, of course, I learned a fair amount of bone pathology when I came to Mass General and did a residency there. And I was on the staff there for about 20 years, and that's really where I learned my bone pathology. But what I sort of would like to do is to start on some very basic bone pathology. And I want to start by looking at this. Can someone tell me, whoever has volunteered to do this, describe what they're seeing here?
It's a cartilaginous scab.
Okay, so it's a cartilage, right? So this is obviously a joint. This is hyaline articular cartilage. Why do you think it's cartilage? What makes this cartilage?
The chondrocytes present.
Exactly, right? So there's something very particular to cartilage, and that is you have these spaces that are referred to as lacunar spaces with nuclei that are very small. So just imagine a big cavern you entering, and so it's sort of an analogy that I didn't quite get to, but the chondrocyte nuclei are typically very small, right? So you have tiny nuclei in a big space, right? So it creates the space, and that lacunar space and that small chondrocyte nucleus is a very typical feature of cartilage. And then there are several types of cartilage, right? Do you know what type of cartilage this is?
This is a hyaline cartilage.
Hyaline cartilage, and it has that very thick, glassy appearance, right? So I mean, thick is a weird word to use when you're dealing with a glass slide, but you know precisely what I mean. It's hard, it's glassy, right? There are other types of cartilage that you'll see as well. I just wanted to point out to you that this is not normal hyaline cartilage. Notice that within this lacunar, can you guys see my pointer?
Yes, sir.
You can?
Yes, sir.
Okay, so if you can see that my pointer here, this is sort of highlighting this lacunar space, and then there are multiple chondrocyte nuclei in there. And that phenomenon is referred to as cloning, C-L-O-N-I-N-G. So cloning is a degenerative phenomenon. So this is degenerative joint disease to some extent, right? Now let's look at the bone. So when you look at this on a low power, the pink stuff is obviously bone, and this stuff is all fat. So you can see there's more marrow than there is bone, just quantitatively speaking. And then when you go on high power, you start seeing this is bone. Bone is typically pink. Bone is typically it's sort of similar to cartilage in the sense that we now call them osteocyte nuclei. They again tend to be small in a big space. That's very typical of osteocyte nuclei. But I want to point out that there are two kinds of bone, right? There is lamellar bone and there's woven bone, right? Which of the two is this?
Lamella.
This is lamella, right? Absolutely, that's because you can actually see the lamellae, right? So here's one, here's a line, here's a line. That means it is mature bone. That means it's been there for some time. And what is really interesting is, I don't know whether you can actually see, they are almost like two seams of bone. So this looks like one piece of bone, and then you see the stuff around it, right? That's sort of as if it's another layer, which is precisely why it is split open, right? So there's space. If the space is artifactual, but the reason why this artifactual space is opened up is because these were deposited at different points of time. So this was the original, and this is the new, right? This is at some point it was woven bone, but it's relatively new because it's a lot more cellular. All right, so lamellar bone and woven bone, and we'll see examples of woven bone. But what I wanted to show you, what I wanted to highlight for you was this, right? So this is the abnormal tissue here. You guys see it? It stands out. So this is the articular cartilage. This is the underlying lamellar bone that we just saw. Right there is cartilage. Now, what do you think of this cartilage? What kind of cartilage is it? Is it benign or is it neoplastic?
It's looking like benign, sir.
Okay, looks benign. Why do you think benign?
Because these nuclei are arranged in like a uniform manner, and there's not much of pleomorphism or etcetera. So I thought this is a benign now.
Okay, so there's not much. So they're pretty monomorphic, but I can tell you that many chondrosarcomas are pretty. Do we agree it's cartilage?
Yes, sir.
Do we think it's cartilage or bone or something else? It is cartilage, right? Because for the same reasons, right? The lacunar space, small chondrocyte nuclei. So it's cartilage, and you think it's benign cartilage because it's very monotonous. Point well taken. But I will point out to you that some chondrosarcomas can be very monotonous, and I will also point out to you is look at the cellularity of the cartilage, right? Very cellular. Use the hyaline cartilage here as your landmark, right? your goalpost. That's normal cellularity of cartilage. This is very hypercellular, so it's very abnormal. And is it hyaline cartilage or some other kind of cartilage? This was hyaline cartilage, remember? This is hyaline cartilage. Does this area look the same or different?
Popular.
Say it again. I'd say it looks different, doesn't it? It looks more fibrous. It doesn't have that glassy appearance. This is fibrocartilage. So this is very cellular fibrocartilage. And I just wanted to point out to you that, so we've now seen 3 tissue types: hyaline articular cartilage, lamellar bone, and now we're seeing this very cellular fibrocartilage. And if you go back on low power, you'll see that fibrocartilage is almost linear. See that? I can draw a straight line. So there's new fibrocartilage that has been deposited beneath the articular hyaline cartilage. So does someone have a diagnosis of what's going on in this case? Is this a tumor?
I thought this is a benign, as I told before, that I thought that is a benign cartilaginous thing. I thought because of that mature hyaline cartilage and that I felt like at one part beneath that cartilaginous cap, I thought there's an enchondral ossification is also there. So I thought it could be like a benign chondral neoplasm, osteochondroma, I thought.
Okay, so that's a good thought. Okay. So I can tell you that this is where imaging comes in. I'm sure we'll talk about this in the end. So this was a femoral head. This was not a neoplasm, right? So you do need to know context, but that's a very good diagnosis, right? If you don't have history, this could be an osteochondroma, right? Because an osteochondroma has underlying bone and overlying cartilage. The one thing that an osteochondroma typically doesn't have is this line, even if you didn't know anything about the imaging, right? You see this line that separates the bone from the cartilage? This is referred to as the tide mark. You don't typically see a tide mark in an osteochondroma, but be that as it will, this was a femoral head, and this was taken out because of what they thought was osteoarthritis. So I know it's sort of it's unfair to put you on the spot, but this is a fracture callus, right? This is what you see when you see a fracture, very cellular fibrocartilage. And you see it's a linear fracture. Fracture is always generally very linear. So this is referred to as a subchondral insufficiency fracture. Now I don't think it matters that much because I primarily chose this case so that I can demonstrate the normal and the physiological changes and some pathology that occurs in the bone. But if you are interested in the diagnosis, this is what is referred to as a subchondral insufficiency fracture. These are people, since we're talking about it, I'll get it out of the way very quickly. These are typically elderly, typically women who present with sharp pain, and then they fracture, and then basically that's the point when they fracture. And this is one of those conditions where the hip can actually be saved if you make the diagnosis preoperatively. And many of these people have osteoporosis as well, but this patient clearly does not have any osteoporosis. So the point of this case was not to focus on the subchondral insufficiency fracture, but more on the normal histological features. But I threw it in there because this is something that perhaps you've never heard of. But if you do look at hips and knees, and I don't know how often these hips and knees get examined histologically in India, probably not. But if they do, you will see every now and then. The most common thing you'll see in a femoral head is osteoarthritis. The next most common is avascular necrosis, and the third, and it's relatively uncommon diagnosis, is the subchondral insufficiency fracture. All right. Any thoughts? Any questions before we move on to the next case? Okay. So we're moving on to case 3. We'll come back to case 2. Okay. Oh, I have a. Why don't we look at the slides and then we'll look at the imaging? Someone want to describe this for me? Case 3.
We have Sharmili, Asmita, and Harshini. Anyone?
Looks blue, right?
Yes.
And it looks like cartilage.
Yes.
Okay. And who's that speaking? Sorry, I can't see your. Who said yes? Sorry, I don't want to put you on the spot, but I'm just curious to know who I'm speaking with. Okay. With me, you can never make a wrong diagnosis. The more the wrong the diagnosis, the better it is for me in terms of teaching. And I promise you, I won't let you go down the wrongs in the wrong direction. I'll rescue you the moment I see you are. So feel free to speak. Which of you is going to speak? Someone speaking? No. Shall I just go ahead? Okay, why don't I just talk? So why don't we do this? I'll ask you pointed questions. Let's start with this. What is this?
Calcification.
No, this. Yeah. But fundamentally, this is your bone and cartilage. Is this bone or cartilage?
Bone. Cartilage.
Okay, it's bone. And why does this area look blue black, and why does this area look pink?
Ossification.
Why the difference? And now it's the decalcification, right? So this has not been fully decalcified. This has been decalcified, right? So this must have had less calcium. So we didn't leave it in decal long enough, which is why some of the calcium is left behind. So when you see this blue thing, it's the same underlying tissue, except that the decalcification has basically gotten rid of the stuff here. So let's then go back to, let's see other pieces. Let's look at a more decalcified piece of bone, and let's decide whether it's lamellar bone or whether it's woven bone. What do you guys? I know it's a little fuzzy here, but what do you guys think it is? Woven or lamella?
Lamella.
Yeah, so it's lamellar bone. So that's very likely pre-existing bone, right? Here's a really interesting area. Yeah? So you see bone here, and then you see fibrous tissue here. Does anyone know what this area is? It's important to know where you are, because remember, these are curettings, and so it's sort of important to sort of pick out what's normal and what's abnormal very early on when you look at a slide. This is the periosteum, right? So this is the cortical bone. There's probably a Virgin canal here. And you can see that it is not normal. Obviously, it won't be normal because it's reacting to whatever the process, the neoplastic, there's a neoplastic process. And so the adjacent bone is sort of reacting to that. But this fibrous layer is the periosteum. This is the cortical bone. So we have bits of cortex, obviously, right? When they go in and curette it, you're going to pick out some pieces of bone and periosteum as well. But what you really want to see is this, right? Can we agree this is cartilage?
Yes.
Yes.
Okay, so again, we've decided that because there are spaces and there are nuclei in there, and there are small nuclei, big spaces, this is cartilage. Okay, so is this a neoplastic, or could this be some sort of fracture callus?
It's not neoplastic.
You don't think it's neoplastic? I should show you the.
It has got few areas of info.
Okay, let me show you guys the. Is this the one? Oh, hang on. So. Okay, so this is the plain film. Let's just go to. Okay, see this? You know which bone we are involved?
Yeah. Lower femur.
Yes, this is part of the femur. So, you know, I'll leave you guys with a little trick. When someone asks you what is the most common site for a bone neoplasm and you know nothing about it, always say distal femur and proximal tibia. In 80% of cases, you'll be right. Whatever tumor you name, giant cell tumor, cartilaginous neoplasms, the most common sites are distal femur and proximal tibia. So, you guys see it? So it's a big mass forming. It's a big mass forming lesion in the bone. Right? So it has to be a neoplasm. And we've decided that it's a cartilaginous neoplasm. What's left? What do you have to now decide? What's left? Are you just going to sign this out as cartilaginous lesion on your plasm? Yes? Someone help me.
Whether it's a benign or whether it's a malignant.
Yeah. Wouldn't you like to know that? You know, if you don't say that, then the next time no one's going to show you any case. So, oh yeah, well, that's not the case. Okay, so what do you guys think? Is this benign or malignant? And how do you tell? There's no wrong or right answer. This is sort of, these cartilaginous lesions, as you've probably seen, are very, very challenging.
So the cartilage is
How do you tell which? It'll have to be one of you at a time. Sorry.
So the cartilage is arranged in the lobulated pattern, sir.
Yeah, we can talk about that. Yeah, okay. What else? I can hear someone whisper at the back. Did someone say hypercellular?
Yes.
You're gonna have to be a lot louder. Anyway, let me start talking. So there's hemorrhage, but remember this is procedural, right? So they got surgeons going in and curating all of this stuff out. That's going to create some hemorrhage. And lobulation, yes, it's lobulated, but some of this could be artifactual. Remember, when they're curating out, they don't carefully curate out one little lobule at a time. They take whatever they use, they sort of take out a lot of tissue, and it all gets mixed up together. It's like putting it into a juicer, and essentially everything gets all sort of squeezed in together. So some of the fundamental rules you talk about in terms of benign versus malignant is infiltration of existing bone, right? Or what is referred to sometimes as bony entrapment. So if to see that, and we'll see that on the next slide, and then in the next case, if you have bone and then there's tumor going through it, right, but in the marrow spaces, that has to be malignant. In general, when you think of bone pathology, one of the fundamental features of bone pathology is if it's infiltrating, it's cancer. If it's not infiltrating, it's benign, right? So it has a circumscribed border around it. And then it's harder to tell that. At least I could not tell any infiltration on this lesion. And so that's one feature in favor of benign. And we'll of course talk a little bit about radiology and the clinical appearance a little bit later. We're still focusing on the histology here. The other feature is cellularity. And think of hyaline articular cartilage as your goalpost in terms of cellularity. That's sort of the normal cellularity of cartilage. This, relative to that, is very hypercellular. Right? Also, the nuclei are larger. Remember, they should be small and lymphocyte-like. And if you look in there are areas in which they are lymphocyte-like, the nuclei, but some of them are much larger. Right? So it's cellular, and it's slightly, that makes it a little atypical. In addition, if you look at it, this is not typical hyaline cartilage, it's a little myxoid. That's another feature that is of concern. So we have at least two features that bring some level of concern in terms of a chondrosarcoma. And essentially what we're trying to do is distinguish between an enchondroma and a chondrosarcoma. So we have some features that speak benign, some features that speak malignant. At this point, you really have to go back to your radiologist. I'm not going to show you the radiology here. It's going to take too much time, but your radiologist, you should never be sending out bone pathology without speaking to the orthopedic surgeon and the radiologist. The orthopedic surgeon tells you that this lesion is associated with pain, that he or she thinks it's associated. The pain is associated with the lesion. That's a very concerning sign. And your radiologist is very, very helpful. So they'll talk about things like enhancement on MRI. They'll talk about endosteal scalloping. They'll talk about cortical breakthrough. And they'll tell you that this is probably benign, or this is obviously malignant, or they could come back and tell you, okay, there are features in between, right? So some of them are benign, some of them are malignant. And so this case, eventually, we signed out as, it was too cellular to be an enchondroma. There wasn't enough evidence to call it a chondrosarcoma. So we used a diagnostic category that is now in the WHO that is referred to as atypical cartilaginous tumor, or ACT. It's sort of between an enchondroma and a grade 1 chondrosarcoma. This is a term, ACT, atypical cartilaginous tumor, is a term that we use in the appendicular skeleton. By that I mean the extremities. We do not use that term in the axial skeleton. In fact, the term ACT and grade 1 chondrosarcoma are synonymous. The tumors are the same. That distinction is largely based on location. So if it's in the pelvis, this lesion would be called a grade 1 chondrosarcoma, and the appendicular skeleton, this would be called ACT. So what does it mean to call it an ACT? It means that there is a greater chance of recurrence, but we think there's almost no risk of metastasis. So the recurrence rates of ACT, I think it's early days yet because this is sort of an entity that we haven't been diagnosing until the new WHO 5th edition came in. The recurrence rate is about 10%. So these tumors will recur but not metastasize. I think the other thing is we pair these patients, calling them sarcoma, and then when you say make a diagnosis of overt malignancy, that's always a great concern to patients. And so I think it's only right to call this. Think of this. The analogy is a typical lipomatous tumor and a liposarcoma. That distinction is not based on genetic or histological features. That distinction is based simply on location. If it's in the periphery, we call it an atypical lipomatous tumor. If it's in the abdomen, we call it a well-differentiated liposarcoma. And that's because in the abdomen, and the pelvis is very similar, it's very hard to get these tumors out entirely. Well, if it's in the peripheral, it's in the hand of the feet, it's easier to resect this, and therefore that we use that. It is a little odd that we use the same terminology. We use different terminology to describe the same tumor, but it is a convenient way of doing this. Any thoughts? So this is an atypical cartilaginous tumor. Any other thoughts? Questions?
Yeah, so Dr. Vikram, if I can comment here.
Yes, please.
Yeah, so my question is like, if it was diagnosed as ACT, so why did we go ahead and do the surgery? Because as you said, it's a Curita specimen, and ACT per se has almost negligible risk of metastasis or 0% risk of metastasis. So are we overdoing this? So
yeah. So I think that's a really good question. So I can't speak for the surgeon, and I can't precisely know why this was curated out. You're right. Most enchondromas are never even biopsied, right? So they're radiologically classical, and no one in their right mind would touch them. I think in general, I think surgeons here we practice in a more litigious environment. Surgeons tend to be a little more aggressive than they would be in India. I'm sure India's getting litigious as well.
No. So we actually. Yes, so we recently concluded this boom meeting in UK in December this year, which was Birmingham orthopedic meeting for consensus on chondroid neoplasm. Yeah. So in that, there were surgeons from more than 160 countries, places, centers. So the main consensus was this: ACTs actually, if we radiologically diagnose them, even if you don't biopsy them, it is fine, because the main challenge is, because as you have shown, some mixed area, some cellularity. So someone will call it grade 1 sarcoma, someone will call it ACT, someone will call it as an enchondroma. So but the good thing is, there is no soft tissue component. The risk of metastasis is 0. Okay, correct. So most of the surgeons have agreed that we can safely observe them rather than doing anything for them, because otherwise we are overtreating. So that was the consensus statement that for ACT, because I think the most important thing here is the radiology rather than the pathology. If radiology shows aggression, as you mentioned, like endosteal scalloping, soft tissue component, so then it goes into a sarcoma, then we should treat them. But pure ACT on radiology, pure cartilaginous neoplasm, I'll say on radiology, intraosseous, with no aggressive feature. So most of us now observe. Yeah. So over the years, I think people have changed now from being less aggressive. Yeah, that's it. I just want to. I'll show some cases later.
That's a very good point. I think the most cartilaginous lesions are not resected, but specifically in this case, I can't remember. Interestingly enough, this was biopsied, and I think there is some thought. I don't know what was discussed at your conference, but lesions that are larger are more concerning. In fact, there are some European pathologists who call a cartilaginous lesion chondrosarcoma just based solely on size. Like if it's 5 centimeters or more,
so for more than 5 centimeters, people used to follow that, but now I think people have refuted that also. We don't.
And I totally agree with that. It's a crazy hypothesis, but people are concerned by size, and if I'm not mistaken, there was pain associated with this case, and I think that probably concerned the surgeon as well. In fact, they biopsied it, and again, I don't think there's a great value in biopsying these lesions either. I'm very skeptical. Because the biopsy will frequently miss the more high-grade areas. We call this an enchondroma on the biopsy after discussing it with the radiologist, because the radiology we thought was quite benign. There was a little bit of endosteal scalloping, but we overall felt that this was quite benign. But yet, I was surprised to see a curettage, and then we are forced to call this an ACT because it's so cellular. In general, I think in this country, there is a lot more surgery that goes on than would happen outside this country.
I think it will reduce. Now we have a consensus statement, so everyone has agreed to that, and I think it will reduce. So,
that should certainly help. Okay, let's look at case number 4. Someone want to tell me a little bit about this?
Sir, here in this case, we can see bony bone.
Yes, bone. Okay.
And so we can see cartilaginous areas as well, areas of chondroid matrix. And
okay, so chondroid, and I'm just going to stop you for a second to tell people why this is chondroid. Because there are lacunar spaces and there's cells in there. Okay.
And it is hypercellular.
Very hypercellular, right? Always think of the articular cartilage as your goalpost, and this is very, very hypercellular. Okay.
And the cells are round to oval, and they have cytological atypia and are pleomorphic.
Tremendous, isn't it? And it's not everywhere, but certainly in some areas you can see these nuclei. This cartilage cell should look like small lymphocyte-like cells. Look at that cell, big vesicular cell. This is like I'm exaggerating, like 1,000 times the size of a cartilage cell. It's not 1,000 times, but I'm just trying to exaggerate to make for effect, really. So not atypia. Okay. What else? Very good. You're right.
At places, osteoid deposition is also seen at some places.
Yeah, very good. Look at that. It's deposition of bone as well. So this is cartilage and this is bone. And in fact, if you look at the bone really carefully, there is some lamellae as well. So this is lamella bone, right? So this is pre-existing bone. This is pre-existing bone. This is cartilage. But then within the cartilage, you're seeing some bone and little slivers of bone. See that? Okay. Very good. Dr. Borges will be proud of your description. You have a diagnosis?
So because of the chondroid matrix, neoplastic chondroid matrix, it can be chondrosarcoma. But since we are also seeing osteoid deposition, so it can be like a osteosarcoma with chondroblastic, the variant chondroblastic subtype.
Very good. Sorry, who's speaking right now? Who was that who gave that beautiful description?
So it's me, Dr. Zainab.
Sorry, Zainab?
Yes, sir.
Okay, wonderful. That was a wonderful description. Thank you.
So may I have permission to read my description, sir?
Sorry, permission to what?
So to read my description.
Yes, please.
So the section shows abnormal chondroid matrix permeating into the bony lamella claviculae.
Very good point. Right, so it's permeating. Okay, go ahead. Sorry. Go ahead.
as well as entering the adjacent tissue, and the tumor shows increased cellularity. Individual chondrocytes are enlarged, show binucleation within one lacunae, as well as multinucleation with high NC ratio, irregular nuclear chromatin, prominent nuclear and mitotic figures also seen so. Scant myxoid matrix also noted at places, and these spindle cells gradually merge with the fibrous cells at the periphery. So the tumor is destroying the bone and growing through the cortex. Bone destruction can be seen at the junction of bone and cartilage. I made it chondrosarcoma grade 2.
Right, but
Am I
yeah, no,
different?
that's a very good description. So let me just, since we're running out of time, let me just show you sort of for the folks that haven't seen the slide. So this was the distal femur, and this was a very large lesion with a big extra osseous component. And so we knew this was malignant, and this was actually called a chondroblastic osteosarcoma on biopsy. No, sorry, I stand corrected. This was one of those cases that was not quite diagnosed correctly, but be that as it may. This is the periosteum here. This is the cortex, and you can see the tumor is permeating through the cortex. But I think the most important point I wanted to make on this case is see this infiltration. So this is pre-existing bone, which is why I sort of started with the word lamella bone. Lamella bone is generally pre-existing bone. That is bone that was there before the tumor came along, right? So this is the pre-existing bone. This is pre-existing bone because this is lamella bone. And notice the cartilaginous neoplasm here is infiltrating around it. That's infiltration. And infiltration is one of the fundamental features, at least under the microscope, of a malignant process. So if somebody shows you a tumor, it may look very bland, but if it's infiltrative, be very concerned. I don't know why that started off. It's my dragon that's listening when it shouldn't be listening. Regardless of how bland a tumor is, if it's infiltrative, it's probably malignant. And if there's nothing else you remember at the end of the hour other than my beautiful bow tie, it is this: that infiltration equates malignancy, right? So it's a high-grade cartilaginous neoplasm that is infiltrative, so it has to be malignant. So then you're thinking chondrosarcoma, but then when you go down here, this is actually bone formation. And here's another principle: if you see a cartilaginous neoplasm with bone formation, that is osteosarcoma. So think of it this way: the bone formation trumps everything else, right? So chondrosarcomas do not produce bone, with one exception, but we won't go there today. So this is a high-grade chondroblastic osteosarcoma. So it's a variant. There are many variants of osteosarcoma, but this produces a lot of cartilage, and because it produces a lot of cartilage, it tends to be diagnostically very, very challenging. There's another interesting twist to this case. If you look at the neoplastic bone here, right, you might look at the osteocyte nuclei here and say they look very bland, but this is sometimes what happens, and this is what makes bone pathology really hard, right? Bone is hard, right? Have you heard that expression before? Bone pathology can be really, really hard, and you should never diagnose it in isolation. I would never move. I wouldn't approach the diagnosis even with a barge pole unless I have a radiologist by my side and unless I have the orthopedic surgeon by my side. And we don't make any of these diagnoses in isolation. All of these diagnoses are made in the setting of a tumor board. Because we make up our minds, right? We do all our molecular tests and immunohistochemistry. In fact, in bone pathology, there's not a lot of immunohistochemistry. There is some increasing use of molecular assay to support our diagnoses, but again, that is few and far between. The diagnosis still relies mostly on histology and relies on heavy. I can't emphasize this enough. Correlation with radiology. Your radiologist, you should always send your radiologist a bottle of wine at the end of the year or whatever you want to give him or her. Maybe a really nice sorry if it's a lady. So you really need to be on good terms with your radiologist. So back to what I was talking about. Even though this is osteosarcoma, you see the nuclei here look very bland, and this is a phenomenon that is referred to as normalization of an osteosarcoma. When they have a lot of bone, those nuclei start becoming smaller. So at one point these nuclei were much larger, but when a lot of bone gets deposited around them, they start becoming small and less atypical. So this is a chondroblastic osteosarcoma, and the big difference is generally chondrosarcomas are not really responsive to chemotherapy, while osteosarcomas are. So if you mistake this for a chondrosarcoma, I said if I misspoke, I said chondroblastoma. If you mistake this for a chondrosarcoma, that wouldn't be good because the therapy differs, and that osteosarcomas deserve at least a round of chemotherapy to reduce the chances of metastasis. All right, any questions on that? Chondroblastic osteosarcoma of the distal femur. This was somebody in their 20s. We don't see any pediatric cases here because we have our sister hospital, the children's hospital, has all of the pediatric cases. We see adult cases. Interestingly, our orthopedic surgeons operate at both children's and here. So the same surgeons operate at Children's Hospital, which is like one of the biggest children's hospitals in the country, and then they come here and do the adult cases, which is really interesting. Let's just do some of these cases really quickly. Anyone have a diagnosis on this one? This is case 5.
So this is a very cellular stratigate with chondrocytes that are showing nuclei which is showing pleomorphism and mild RTPR, and hyperchromatism can be seen in few cells, few nuclei. Cells are binucleated and multinucleated scenes. Inflammatory infiltrate is also seen in this case.
Okay. What do you think this is? It's very hard because remember, I have not given you any history. I've not told you what bone is involved. So, it is completely unfair to expect you to even come up with a diagnosis, but that's a really good description. So let me just take it from there just so that, and in the interest of time, what's very interesting about this is there is matrix, right? And if you look at it, if you look at a cursory look at it, it looks a little like cartilage, right? Like myxoid cartilage, except that there aren't convincing lacunar spaces, right? Like there's no space within which cells are buried in. And then the cells are sort of rather cohesive. They're sort of sticking together. See that? It's like they're sort of hanging on to each other for dear life, right? As if this cell doesn't stick to this cell, it's going to go and obliterate or something like that. They're just very sticky. I'm trying to find the right analogy. I can't find it. And they're present in cords. Right? Anyone know what this is? Some of these, they're not infrequently mistaken for chondrosarcomas. And this is malignant, right? It's just too cellular and too atypical. There's nothing benign in the bone that could look like this. Anyone have a
thought it as chondroma.
Mimic of chondroma. You're close enough. It's a chordoma. It's a chordoma. Right? So it's yeah, exactly. I don't know if that's what you wanted to say. But this is a typical chordoma. It's a mimic of a chondrosarcoma, and so I have they're often mistaken for chondrosarcomas, particularly the myxoid chondrosarcomas, right? So think of it this way: chordoma, chondrosarcoma. Chordoma, cells are friendly, they stick together, right? In chondrosarcoma, the cells are unfriendly and they don't stick to one another. I don't know whether you're going to be able to remember that, but chordoma is the friendly one. The cells stick together. It's an epithelial-like tumor, and so these tumors are positive for keratin X100. And does anyone know what the transcription factor we use to confirm a diagnosis of chordoma? Brachyury. So this is very typical chordoma, which is often mistaken for a chondrosarcoma, particularly in the base of skull. Remember, chordomas are mostly in the base of skull and in the spine. Very, very rarely you can have extra-osseous chordoma. Okay, let's just do this one, which is case 7. Another cartilaginous lesion, right? It's somewhat of a cartilaginous lesion, although it doesn't typically have those lacunar spaces. I don't know what that is. It doesn't typically have lacunar spaces, but it has a very lobulated pattern, right? Here's the pre-existing bone. It's not infiltrating the bone. It's very lobulated. And if you look at these cells, they have a very characteristic hypocellular center, which is slightly myxoid, and a slightly more hypercellular periphery. See that?
Yes,
and then that pattern recreates over and over again. See, there we go. Big, these nodules, very myxoid, and then the periphery is very cellular. Yeah. Anyone have a diagnosis? It's a chondro myxoid fibroma. Chondromyxoid fibroma. And if I were to ask you, so this is one of the most pretty, we just had this the other day, one of the most pretty cases of chondromyxoid fibroma that I've seen in a long, long time. And they're very typically like this. They don't come, the lobules have actually fallen away from one another so as to highlight the presence of lobulation. But they very typically have the hypercellular periphery. And when you go down on very high power, you see almost these stellate spindle-shaped cells. It's part of the cartilaginous tumor family. It's totally benign, but it doesn't quite look like cartilage. And where do you see them? Same thing. When someone asks you that question, you always say distal femur, proximal tibia. That's the other thing I want you to remember. If anyone sort of asks you, what's the most common site? Distal femur, proximal tibia. And generally, you won't be wrong. So that's chondromyxoid fibroma. And then lastly, I just threw this in because it looks a little cartilaginous, but it's not. Or maybe it's even bone forming. Does anyone know what this is? Case 6? This was in the soft tissue, by the way. This was associated with a tendon on the hand. This was a 22-year-old boy. Yes, man.
Sir, aponeurotic fibroma.
Very good. Calcifying aponeurotic fibroma. Very good. So this is one of these spotters. Like, once you've seen one of these, remember, this is not in the bone. All of the other tumors I showed you were in the bone. This is in the soft tissue. There are areas that look a little cartilaginous, right? So like here, there's some, that looks like a chondrocyte with that lacunar space. Then there's heavy calcification and there's very spindle cell proliferation. It looks a little like fibromatosis, but it's too cellular for fibromatosis. And it has this big chunks of calcification. Whoever made that diagnosis, can you tell me a little bit more about calcifying aponeurotic fibroma?
So it's a rare tumor which is mostly seen in children and adolescent age groups, sir, and usually involves the distal extremities. And the most commonly seen in that aponeurosis tendons and fascia, sir.
Very good. Yeah. So hands and feet of kids typically, it's a benign tumor that tends to recur a lot. Anyone know what the fusion is? Everything is a fusion right now. I don't know. It's become so confusing. I remember when I was training, it was all chromosomal translocations, and that's all you have to remember. FN1, EGF, yeah. So epidermal growth factor and fibronectin 1. You don't need it. I think in most cases, like in this case, you really don't need a fusion. We only do it when we are stuck and we can't make, we're unable to make a diagnosis. So we use a lot of genetics, a lot more. I mean, I think every year we are more and more dependent on genetics now in bone and soft tissue pathology. But if you can make the diagnosis on the H&E, if you can, and never radiologist and the orthopedic surgeon, they particularly an experienced orthopedic surgeon, I'll typically pick up the phone and say, do you think it's this? And they'll tell me, oh, no. In fact, we had a case this morning we were discussing, and the differential is between a telangiectatic osteosarcoma and an aneurysmal bone cyst. And the clinical picture was very weird. Histologically, I thought it was an aneurysmal bone cyst, and I said so. And the radiologist and the orthopedic surgeon said, no, we're very concerned about this. And so we stopped. Then I said, maybe it's a giant cell tumor with secondary aneurysmal bone cyst component. We have an immunohistochemical stain for that, G34W, which is one of the histone proteins, histone modifications. And then for an aneurysmal bone cyst, we said we'll fish for USP6. So unless I have molecular confirmation, I am not going to call it, because the differences between offering preoperative chemotherapy and just, if it's an aneurysmal bone cyst, they're just going to go ahead and cure it. So there's a huge difference in the outcome. So those are the cases we will work up the molecular aspects of the case, but in the vast majority of the cases, it's based on H&E. Orthopedic pathology is still largely an H&E diagnosis. So good H&E is all generally required. Imaging and a good H&E, those are your two keys to making good diagnoses in orthopedic pathology. And I think that with that, I'll stop, and then Manish should probably take over. And do you have a presentation?
Yes, a small one, maybe around 15 slides, just to make them. Yeah, so because I think most of the time you were emphasizing on imaging, and I think in many of the centers, like our pathologists do not have access to a good radiologist. That's a challenge actually, because a good bone radiologist who can understand these nitty-gritties of a good imaging. So I want like most of them to have some idea of imaging, okay, because that helps them in actually making a diagnosis quite easily or maybe more confidently. So let's go through some cases which will definitely help you in understanding what Dr. Vikram was about to highlight, the role of imaging. Okay, so just so can you see my presentation?
Yes.
Yeah.
You can make it full screen.
Yeah, I did that. Yeah. So think the easiest scenario is something when you see this bright lesion on MR, as you can see in the lower image, and a lesion in the toes or in the hands of. So basically in the phalanx.
Manish,
so
can you use the laser pointer? Manish, can you use the laser pointer?
Sir, I tried actually, because I'm doing from keynote. There is no pointer actually. I tried at 6 o'clock also with your assistant, but we could not find out.
Not even pen. You can't use pen. You can't use pen.
Sir, I can't see it. Sir, I tried that, but it was not. There are only few images only. I think I can easily step up and down. Right? It's very easy. I highlighted the image. So as you can see that there's a lesion in the middle phalanx in the toe on the image up. Okay, and this is a very common scenario. We see very often these kind of lesions very often, and these are like enchondromas. We are very confident about the diagnosis, and all these cartilaginous lesions are bright on MRI. As you can see in the image below, they are very bright. And in hand and feet, we are more or less confident that these are enchondromas. But the problem happens when these lesions appears in the long bones. Okay, as Dr. Vikram has shown a distal femur case. So this was another case which presented to us, like 60-year-old male, poliotic limb. He fell while walking and he complained of pain in the knee. Now someone did the imaging, as you can see, there's a big lesion in the lower end femur. You can see the medullary lesion, which is very well visualized. And these were the MR. And you can see in the MR, there's a very bright lesion in the lower end femur. You can see some contusion also in the patella. You can see that the patella is enhancing. This was because of the injury that has happened. And the lesion is quite big. It is more around 5 to 7 centimeter, and that is the challenge that we are going to face. The radiologist has given an impression of enchondroma, low-grade central chondrosarcoma, or chondromyxoid fibroma, and he suggested biopsy. So the main challenge is, first thing is, does this lesion need a biopsy, because this patient was fine before a fall, there was no pain. And the second challenge is now, because the radiologist is confused between enchondroma and low-grade chondrosarcoma, are you going to help him out after we do a biopsy? That's the main challenge in low-grade central cartilaginous lesion, and that is what about the consensus meeting was all about. So anyway, I'll just describe you like lesions need biopsy. So there was a beautiful paper on when to biopsy solitary cartilaginous tumors, because this describes the aggressive criteria in cartilaginous tumors. And as you can see, there are certain aggressive criteria, like if there's a pathological fracture, if there's a periosteal reaction, if there's a permeation, if it is destroying the cortex, or there's a soft tissue mass, then definitely it needs a biopsy. But the problem comes when these criteria are not there, aggressive, when the lesion is not like painful at all. But we have done certain active criteria, which Dr. Vikram was also finding the pain related to lesion. Then there's something called as endosteal scalloping. Okay, I'll show you some pictorial diagram what I mean by endosteal scalloping. Then there is cortical remodeling or cortical thickening or the enlargement of medullary cavity. That is actually very suggestive of a chondrosarcomas. So see this pictorial diagram. Suppose these white are the cortices. Okay, and there's a lesion here in the lower part, which is causing an endosteal scalloping, which is causing a partial destruction of the cortex. Okay, and as you can see, it is less than 50% of the cortex. But if it is bigger, if it is more than 2/3, then we call it a significant endosteal scalloping, and that is where we suspect a chondrosarcoma or an enchondroma. Okay, so endosteal scalloping more than 2/3 of the cortex thickness, or total length of lesion. Total length of lesion is not important. Like if the lesion is 6 centimeters, is not important. But if the scalloping is more than 2/3 of the length of the lesion, that is very important. Okay, so total 6 centimeter lesion, scalloping of 4 centimeter length, that is very significant. Scalloping of only a focal scalloping, it is not significant. So scalloping of more than 2/3 of the cortex or more than 2/3 of the lesion length is very significant, and we should suspect chondrosarcomas there. So going back to like how we follow, if only one aggressive criteria, we should biopsy. If there are two active criteria, we should do a biopsy. So this patient, I've now zoomed in the radiograph, and as you can see the radiograph, there is no endosteal scalloping. The patient was not painful, although the lesion length was 5 centimeters. So this patient actually didn't need a biopsy, because this patient was having an enchondroma, although at 60 years, it was a well-differentiated cartilaginous neoplasm lying there, and he didn't need a biopsy. So if you know your radiology, you know that there is no endosteal scalloping. Even if the biopsy comes to you, you will not call it as a chondrosarcoma. And this patient actually was reported by Dr. Borges, because the patient had a biopsy, and as you can see, Dr. Borges is very clearly reported as a well-differentiated cartilaginous neoplasm with area of mixed change. And she also again emphasized that it requires a careful radiological imaging review to rule out a low-grade chondrosarcoma. And as I've said, we have reviewed the radiology, and there is nothing suggestive of that it's a low-grade chondrosarcoma, because all these criteria, there was nothing there. There was no pain, no endosteal scalloping more than in the 2/3 thickness, more than the length, no cortical thickening, no expansion of medullary canal. So we knew this is an enchondroma. For maximum it can fit into an ACT. We don't need to touch it, and we can easily observe. That is what I did for this case, and he is fine now. I think this report was 2015, and now we are 2024. 9 years is fine. There's nothing happened. So that is what we should understand, that the radiology is very important. Even if the pathologist will always see a cartilaginous neoplasm when the radiology is showing a bright signal in the cartilage, but not more, like many of the time it is an enchondroma or an ACT which does not need a surgery. It is not a chondrosarcoma. So see this case now. So in this case, we have all the features which can suggest an aggressive lesion. You can see the endosteal scalloping has completely destroyed the cortex on the lateral aspect in the X-ray which is shown above. And in MR, you can see a soft tissue component also in the lesion, which is broken out of the bone. So when this is the situation, we know now it's an aggressive cartilaginous neoplasm, and we did a biopsy in this case, and it was a dedifferentiated chondrosarcoma. So it is very easy to remember. It's a simple algorithm that we need to follow. If there is not significant endosteal scalloping, no soft tissue component, no periosteal reaction, and no pathological fracture, we know we are dealing with a benign kind of our low-grade neoplasm which we can skip. And there's a very strong data now that if a cartilaginous neoplasm has not broken out of the bone, it will not matter. Okay, so if it's a pure intraosseous tumor, you can safely observe for 3 months, 6 months before doing a biopsy. So another case, just to emphasize the same fact, like this was a 27-year-old male, had a surgery at the same site 6 years back. At that time, it was called an enchondroma. Now presented with the recurrence. These are the follow-up X-rays. Now you can see there's a big recurrence in the lower part of the lesion. Now the medullary canal is expanded. This is what I mean by expansion of medullary canal. You can see the tibia from the lower end, and it is expanding now. Okay, and so there's a recurrence with an expansion of the medullary canal. And if you see the MRI shows a cortical destruction. There's a soft tissue component which is coming in this imaging. Okay, you can see on the image which is coronal section. On the outside, there's some cortical destruction. The black line is getting broken, and there's a soft tissue component. And same in the axial, you can see a soft tissue component on the top right image. Okay, so when these are there, we know that we are not dealing with an enchondroma. We are dealing with a chondrosarcoma. But the problem is, we did a biopsy. Our pathologists were very experienced, but they still call it enchondroma, because the challenge here is they see a well-differentiated cartilaginous neoplasm. Okay, but that is why emphasizing speak to a radiologist, because this was not an enchondroma on radiology. So we planned for a resection here. We did a proximity resection, and this was the final biopsy report. It was a chondrosarcoma grade 2. So without a radiologist, even if you are seeing a well-differentiated cartilaginous neoplasm, so you will do a mistake, because radiology will give you subtle clues that it is more aggressive than what you are seeing on a small needle biopsy. So that is very important. You can see in the final specimen, but in a small needle biopsy, you can miss the permeation, you can miss a ATPA, or you can miss the small hypercellularity. So basically, this is what Dr. Jambekar has always taught us. It's a jigsaw puzzle. Everything should fit. If nothing is fitting, if something is not fitting, then there's something wrong in the case. So again, you can just follow the same criteria. There was a soft tissue component here, so we know it was an aggressive neoplasm. And then we need to think of it like a more aggressive rather than an enchondroma. So another interesting histology that you will sometimes see, and which will usually give a very long history, like this patient had a history of 9 years in a 37-year-old male. So 2009 it started with a small epiphyseal lesion in the femoral head, as you can see in the imaging. Then 2012 the lesion grown a little bit. So everyone at this point of time called it as an avascular necrosis of the femoral head, and they just kept him on observation. Then in 2018 it became little bigger. Finally someone thought, okay, it's something wrong, so I'll just do a, he fractured, and someone thought I'll do a hip replacement. But during hip replacement they found some bad tissue inside, so they didn't do a hip replacement. They just resected the femoral head and sent it to a pathologist. So Dr. Vikram can comment there, but I think someone has called it as chondroblastic osteosarcoma. But because chondroblastic osteosarcoma will not be having a 9 years history, these were his slides. It was reviewed with us, and the radiology was not fitting into chondroblastic OTS over 9 years history. So this was actually called as a clear cell chondrosarcoma. So this was a clear cell chondrosarcoma, very classical location and very classical picture. A clear cell chondrosarcoma usually is an epiphyseal lesion, grows slowly, and it keeps increasing in size, and it can be confused with chondroblastic osteosarcoma. I'm not very good in pathology, I cannot comment it, but that was being the confusion. So basically, in cartilaginous neoplasms, you need to know the radiology well. You need to know the site of the lesion, age of the patient, and you should know the some criteria. There are very good scoring systems. One is now a RAS, which is called as RAS, Radiographic Assessment Score. You can download that article. Any cartilaginous neoplasm, just go to the radiology, put that RAS, you will get an idea what are you dealing with, or use the paper that I've quoted. So I think with that, the cartilaginous neoplasm, you should know the radiology well. Otherwise, you will keep doing the mistake because you will keep calling it high grade, and otherwise it could be a low grade or the vice versa. That's it from my side. I think that's more than enough for them for the radiology. Yeah.
Thank you very much. Actually, Vikram had to leave for a meeting. Now there are some questions in the comments chat box, so I think I would request that students keep these questions for the Tuesday meeting when Vikram comes back.
Yes, sir.
And we will tell Vikram to give us more time. But if anybody has questions for Dr. Manish, he will be happy to answer. There are not many questions. Manish, you want to say any final comments to students?
Yeah, sir. So I think the cartilaginous neoplasms stress now more on radiology than pathology, because most often than not, they will be able to diagnose a chondroid neoplasm. Okay, the diagnosis of chondrosarcoma is more radiological than pathology now, unless it's a DD chondrosarcoma or a high grade. The challenge comes between enchondroma and grade 1 chondrosarcoma, and that is a radiological diagnosis, that's not a pathological diagnosis. So grade 2, 3 they can easily diagnose, DD they can easily diagnose, but between low grade and enchondroma, the diagnosis is only radiological, and the treatment also depends upon the radiological diagnosis rather than pathological diagnosis. So that is where they should actually see the radiology well. They should at least have some idea of people who are good radiologists who can guide them. Okay, this is not a chondrosarcoma, this is an enchondroma or the other way. So that is very important, and that they should incorporate into their habit.
Students, do you have any questions for sir? I think they are happy. They look happy and contented. At least all students are here, but I can see a video of 4 of them. So if there are no more questions, then I can see one more now popping up. Zainab has popped up. Good. So there are no more questions or comments. I would just to finalize. Thank you very much, Manish and Vikram, for making it so simple and crisp. This difficult topic, chondroid. I'm sure these are rare tumors, and so not many colleges, students get to see. Even teachers do not get to see it. So in the continuation of this, on the coming Tuesday, we have a talk on lesions